The following podcast is part of a certified educational activity titled Harnessing Precision with EGFR-Targeted Therapy in Resectable Non-Small Cell Lung Cancer, Evidence, Cases, and Considerations for Multidisciplinary Patient Care. Access the entire activity and complete the post-test at peerview.com/UKV860. Downloadable slides and practice aids are also available.
Hi, welcome and good evening, everyone. Thanks for joining us tonight. We're going to be talking today about harnessing precision with EGFR-targeted therapy in resectable non-small cell lung cancer. And we're going to do this in a nice interactive way with some evidence and a case-based multidisciplinary approach, kind of like a tumor board that you would have. So thanks for joining us. I am Gavit Woodard. I am an assistant professor of thoracic surgery at Yale School of Medicine, and I am joined today by Dr. Catherine Hsu, who is the director of thoracic medical oncology at Columbia. So welcome, Kathy. Thanks for being here.
Thank you.
So our goals for today, we want to augment your knowledge of the latest evidence of EGFR-targeted therapy in resectable non-small cell lung cancer, and we want to equip you with skills for developing individualized treatment plans for patients with resectable EGFR mutant non-small cell lung cancer. So to get us started, the point of this is that first, to identify those patients with EGFR mutant cancer, we have to find the target. Okay, so the reason why it's so important to test for EGFR mutations in lung cancer is that it's a very frequent mutation, especially in patients who are never smokers. You may see this in younger patients or places that have more Asian patient populations. And so here are some prevalence rates of EGFR mutations based on the stage. So across different stages, in stage 1, 20% rate of EGFR mutation, 18% in stage 2 and 3, and as high as 26% in stage 4 non-small cell lung cancer. And as much as we think we're doing a better job, and we are doing better than we used to related to biomarker testing, there's still a gap in who gets biomarker testing, especially among early stage patients with non-small cell lung cancer. So below, here are some results from the MyLung Consortium. These are the rates of biomarker testing in early stage non-small cell lung cancer. We do the best right now for identifying PD-L1 status. EGFR is next after that, but you can see the patients who are early stage who have EGFR testing done, there's still about a third of patients that we're not doing this testing for. And then when we are doing testing for patients, it's really important. We'd ideally like to get these results back within the first few weeks of diagnosis. And so the sooner we can do this testing, the better. How long is your turnaround time, Kathy?
It's about 2 weeks, probably. I mean, the good thing is that it's a reflex done by pathology. So I've had patients come from some other institutions where it has to be reflexed by the medical oncologist, and then it's like 2 weeks before they see the medical oncologist, and then it's another couple of weeks from there. So I think it's best if it can be reflexed through pathology, but it's a work in progress, I think, for all institutions.
I think the other challenge is to know when you're going to test your early stage lung cancer specimens. Are you doing this off of a biopsy, which may have a more limited amount of tissue, or are you going to test based on a surgical specimen? And so ideally, if we're trying to identify patients early on who might be candidates for EGFR-directed therapies, the sooner you can test, the better. But again, we are limited in some ways based on the amount of tissue that might be available.
Yeah.
Do you guys test your biopsies before they go to surgery?
Yeah. We any new diagnosis we test. So if and nowadays the interventional pulmonary people are pretty good at their biopsies. We get pretty much always sufficient tissue for testing.
Yeah. Our goal is to test on the biopsy, and then when the surgical specimen comes out, if it's very early stage, testing is not repeated at that point.
Same
The sooner the better should be the mentality, as long as you have sufficient tissue to do it. All right. And so still related to the gaps, thinking about the first systemic therapy that's given to patients who are diagnosed with EGFR mutated non-small cell lung cancer. One thing that I think is very important for us as surgeons to recognize is that the most appropriate therapy for EGFR mutant patients may not be immunotherapy, and that is still immunotherapy is an exciting area for us in the neoadjuvant setting, but it's really critical that we make this distinction between EGFR mutants and patients who are wild type EGFR to direct them to the right therapy up front. So we're going to go through some cases in a little bit where we look at different patient examples for this. But I think when there's, PD-L1 is negative or unknown, in those patients, they're much more likely to get an EGFR-directed therapy. But I think a lot of people are still being fooled. If you have high PD-L1 expression with an EGFR mutation, it's tempting to want to give immunotherapy to those patients, but we really should be triaging these patients appropriately.
Yeah, and that's a really important slide. I tell everyone, all my fellows, just if you see the EGFR mutation, just ignore that PD-L1 because a lot of times they have high PD-L1 and it just doesn't mean anything.
Yeah, we have another slide on that coming up in a second. Sure. And so when the timing of testing, we kind of touched on this already a little bit. You can test patients at the time of diagnosis. There's a new lung nodule found. This is detected, and now we're going to do a biopsy. And so this is your first opportunity to look for EGFR at this point. If there's not sufficient tissue, they can go back for a rebiopsy. Sometimes we look in the blood if we're really concerned. But depending on the stage of your patient, if you're thinking about a stage 1 patient or someone who's a little bit earlier, that testing may not happen right away. So it's really important then at the time of surgical resection, that's your second time point when you can send these patients tissue for biomarker testing. And all of this is done as part of a multidisciplinary team, communication between the surgeons, the oncologists, the interventional radiologist who might be doing the biopsies, or your pulmonologist who might be doing the biopsies, making sure if you are sending a patient for a diagnostic biopsy that you are communicating with the teams that you work with, that it's really critical to get sufficient amount of tissue to do this biomarker testing. All right, I'm going to turn the floor over to you, Kathy, and we can start doing some cases.
Okay, great. Thank you again to PeerView and to AATS for having me. I'm a medical oncologist, so I'm not a surgeon, but I work with a lot of surgeons, and I love you guys, and so thank you for listening to me tonight. Also, this is a topic that's very near and dear to my heart, EGFR. It's my favorite topic, so I'm really happy to have you guys here. We look forward to having you guys ask questions, and we're happy to make this as interactive as possible. So this is a patient of mine. She's 64. She's never a smoker, and she actually got a chest CT because she had COVID at the time and had some cough. And the chest CT shows a 3.4 centimeter left upper lobe mass, which you can see there. This was followed up with a PET scan, and it was FDG Avid 5.3. Everything else looked okay. No mediastinal adenopathy, no distant disease. I'm just going to pause here for a second. Gavit, is this someone that you would do mediastinal staging on, or is this someone like we would just kind of move forward with?
We feel pretty strongly about getting pathologic staging of the mediastinum on everybody, especially someone who has a 3.4 centimeter PET Avid tumor. That is, this person would be going for an EBUS at Yale. What about you guys?
Yeah, I mean, we do too. I think she's like kind of at that cutoff where maybe sometimes people wouldn't, but in general, I always think it's better to oversample than to not. So this woman went for EBUS. They took a look. They didn't see anything. They did a few biopsies. Nothing came back positive. And then while they were doing that, they did the transbronchial biopsy. And that shows invasive lung adenocarcinoma. Okay, so we took her straight to the... Oh, actually, before we take her to the OR, her NGS panel comes back, and she has an EGFR exon 19 deletion. Okay.
I think that distinction of, whether people get, triggered to send molecular testing early or not when there are 0 lymph nodes involved is an important point, because I think this does become a critical issue for a lot of surgeons, is like, what's the extent of nodal involvement, and how prone am I at this point to start thinking about a neoadjuvant pathway versus a straight to surgical approach?
Yeah. And for us, I think just to make life easy for the pathologist and to make sure that we capture all of the tissue, we just tell the pathologist like any new diagnosis that like they don't have to like figure out what stage the patient is, and they don't have to, they just send it for molecular. So this patient has an EGFR exon 19 deletion. Well, she's taken to the OR, which is exactly, like I think having an EBUS that's negative, otherwise just like a nice, juicy looking tumor. She goes to the OR. It's a left upper lobe, and it's a 4.4 centimeter invasive adenocarcinoma. But here we go. It extends into the visceral pleura. Multiple lymph nodes are involved, 2 level 5, 1 level 7, 2 bronchial.
Multi-station
So,
too.
yeah, so it's, this is, we always tell the fellows, like, well, there's can always be surprise N2, right? So this is PT2B N2 disease. So this was a little bit surprising. So what do we tell the patient now? So we're gonna come back to this case. I'm gonna leave you hanging for a minute. We're gonna come back to this case after I review some data, and then I'm curious what everyone thinks.
And then we also have some good questions coming in on the chat that we can work into some of this discussion.
Okay, great. So first I'm going to talk about ADORA, which was a really important study, a phase 3 trial looking at adjuvant osimertinib in stage 1B to 3A non-small cell lung cancer. So these are patients who had resection of their tumor, and it was investigator's choice whether or not to get chemotherapy. And then these patients were then stratified by stage and type of EGFR mutation and race, and they were randomized 1-to-1 to osimertinib versus placebo. The primary endpoint is DFS in the stage 2 to 3A, and originally the trial was planned for treatment duration of 3 years, and the trial was ongoing, but actually the study was unblinded early because of the efficacy, and at the time of unblinding, the study had completed enrollment and all patients were followed for greater than a year. So you're going to see here. So this was the ADORA primary endpoint, and I think it's always incredible to me every time we see these curves because we're all, people who are old like me now, we're used to seeing curves that basically like, all the platinum-based chemotherapies, everything looks exactly the same. And to have any sort of hazard ratio like this is really incredible. So you can see in the stage 1B to 3A and in the stage 2 to 3A, that hazard ratio was really impressive. It was like basically an 70 to 80% improvement in the risk of recurrence. And so we all kind of were really impressed with this data. And I think the question was whether or not it was just improving your DFS or was that actually going to carry through to OS. And so this was actually presented by Roy Herbst 2 ASCOs ago now. We were all really looking forward to this. Is it that OC kind of pushes back your recurrence when the disease comes back? Is the disease going to be more aggressive? But ultimately, this is what we saw with improved OS. And this to me is really telling. So that hazard ratio is 0.49. And when you look at stage 1B and stage 2 to 3A, it's pretty similar. And you can see that the osimertinib arm continued to outperform that placebo arm by a lot. If we looked at this nice tornado plot looking at basically disease recurrence, and you can see in the overall population, fewer patients in the OC arm had disease recurrence. And kind of importantly for me, the CNS here, this is really important, right? Because we know that osimertinib has really good blood-brain barrier penetration, and we know it can prevent CNS lesions as well. So that's really important to me. And otherwise, you can see that local recurrence is probably otherwise the most common.
And now we have the overall survival data, but while we were waiting for that for a very long time, the rate of CNS recurrence was a big argument for giving OC and that it was protecting the patients from brain mets, even in the absence of a survival benefit, which now we have that as well. But so preventing the quality of life detriment that would come with having an early brain met was a big argument for using OC.
Yeah, absolutely. And I'll tell you, even before the OS data came out, when that PFS data came out, I was already giving it to all my patients because, DFS is also a really important endpoint. I mean, these patients they don't want their disease to come back. It's very stressful. There's a lot, to be said about that. So I was giving these patients adjuvant OC. This is really important to me because I think a
This is
lot
a
of
chat question too.
this is a chat
This
question.
is a
Okay,
question
great.
off the chat. So
Good.
or
Because this is a question that no one really knows. The patients come to you and they're like, "Oh, osimertinib has such a great benefit, but like, can I just not do the chemo since we have osimertinib?" And remember, that was not the question that Adora asked, right? It wasn't whether or not chemotherapy followed by OC was better than no chemotherapy followed by OC. The chemotherapy was investigator's choice. And what we know is that patients did better if they got adjuvant chemotherapy, and they did better if they didn't get adjuvant chemotherapy. So either way, the patients did better. And so this is a little different than like some of the from like Alina, for example, the ALK adjuvant trial, which didn't use chemotherapy at all. So to me, I think there's still an additive benefit to chemotherapy. And for my patients, I tend to still recommend it, especially in patients who are stage 3. In the stage 2s, they can talk me out of it, and certainly in the stage 1Bs, it's okay. We just go ahead with it with the osimertinib. But I think this is an important point.
I'm going to give you another quick
Yeah.
question off of the chat. It's about how this might relate to a smoking history, and if there are any differences if your patient is a never smoker versus someone with a smoking history to the outcomes that we see with adjuvant OC.
Yeah, I don't think so. It's really just more like that pretest probability of whether or not they'll have that EGFR mutation. But I'm always surprised by the patients who have a smoking history and have an EGFR mutation. But we see it all the time, and that is why we need to test every single patient, because if you don't, you miss those people, and they do just as well. So I think it's important. You can see here that the drug is really quite well tolerated. The grade 3 to 4 tox is very low. Most of the times we're seeing just grade 1 to 2, and it's diarrhea, paronychia, rash. Those are really the main things that we see. Some of these other ones, stomatitis, mouth ulceration, we see those, but and decreased appetite. That one we see it quite a bit. And then you can get interstitial lung disease pretty rarely, but it's something that we watch for, or like QTC prolongation. So I always get them EKGs at start. But in general, the drug is very well tolerated. And I would say most people are able to get through all 3 years. So this was really big news. The FDA approved osimertinib as an adjuvant therapy after tumor resection in patients who have classical EGFR mutation, so that's exon 19 deletion or L858R. There are some more studies that are ongoing. There's ADORA 2 that's looking at even earlier stage cancers. Stage 1A, this one has completed enrollment, and we're awaiting results on this. But this is a question that comes up a lot because we see a ton of these patients, and they're always asking me, should I be on osimertinib as well? And I don't know, but we can stay tuned to find out, right?
I think we see plenty of patients who come in and want to be on it because they somehow heard about this data or Googled EGFR mutations. And so I think frequently patients are looking for options like this.
But I mean, so I think even though I just said the drug is well tolerated, like we want to see that there's actually efficacy, right? Because it's still like 3 years on a pill that has its own lifestyle toxicities and things too. So it is, I think, important to do.
And also as surgeons, we like to think that we can tell a patient who comes in and looks for everything that we can tell at the time of initial staging that they have a stage 1 lung cancer. It's tempting to want to tell these patients, we can cure this with surgery and then you'll be done and you don't need anything else. And so one of our questions coming in from the chat was kind of when to initiate conversations with patients about potential oncology referral. And I think it's probably a good practice never to totally close that door and always leave, we don't know what the lymph nodes are going to show. Treatment has become very multidisciplinary these days, and we have some great opportunities. I like to tell patients that they're like, we now have really great drugs. And if you're lucky enough to have one of these mutations, you might be a candidate for some very effective adjuvant therapy. And to frame it that way to them as part of my initial conversation as more of an exciting thing, because we didn't used to have these options for lung cancer. And it's actually really great to be able to offer these to patients now.
Yeah, no, that's a great point. And to all my surgeon friends out there, you know, sometimes surgeons tell the patient, "Oh, I got it all." And, sometimes you do have it all and sometimes you don't, but it becomes a little harder when the patient comes back to you and it's like, how could how could this be like this? Because the surgeon told me he had it all or he had it all. So, I think that's a really good point. The earlier you kind of bring up any of these possibilities, I think the better. Um, this is another study that's looking at 5 years of adjuvant osimertinib. So I think we're always wondering, what's the right number, and I don't know right now, but this is interesting to find out. Some of my patients who have now finished 3 years of adjuvant OC are asking to stay on it, and I've been convincing them to come off because that's just what the data is. But I'll be interested to see, what this study shows.
I think earlier today at a session, Jessica Donington said anecdotally she's sending circulating DNA for patients, and for patients who have it initially, who clear it while on OC in the adjuvant setting,
Yeah.
they're leaving those patients on therapy.
Yeah, it's very controversial.
Yeah.
The problem with ctDNA also is sometimes patients who are they get very anxious about it, and then you have to deal with a lot of anxiety too. So I do both. I will send ctDNA, and but in patients who are okay, just kind of with surveillance, I let them be. Okay, so let's come back to this case now. So she's a surprise N2, and what are we thinking now that we know this data? What do you think, Gavin? This was a surprise to you, right?
Surprise N2. So, hopefully this is someone that I would have said, let's wait to see what your path is before we tell you you're all done. I think especially this tumor was greater than 3 centimeters, so I would be a little suspicious that we might be dealing with potentially more advanced disease. And so this is when we would send them to an oncologist to talk about adjuvant therapy. I would think about that even in the absence of an EGFR mutation for this patient, because they have more than 4 centimeter tumor. They've got multi-station N2. This is a patient who needs adjuvant therapy.
Okay. So this person was referred to see me. She underwent 4 cycles of adjuvant cisplatin pemetrexed. I convinced her to do the chemo because she was stage 3. I thought she was pretty high risk. She was otherwise, completely healthy person. So I convinced her to do it, and then she did 3 years of adjuvant OC. So I started this woman before the OS data came out, but she's done already, and she's doing great. She's stopped the 3 years as well.
Nice success story.
Yes, hopefully. Okay, so what about in the neoadjuvant space? What's the data for EGFR there? And I'm gonna.
All right. So this is a nice more surgical case that gets into kind of resectability. This is a little bit trickier situation, as the surgeons in the room would agree. It's a 71-year-old man. He's a never smoker, but otherwise pretty healthy, and he's presenting with a cough. On his workup, he's found to have an almost 6 centimeter tumor in the right upper lobe. It's abutting the mediastinal pleura. There's a 2.5 centimeter satellite lesion, and some right hilar lymphadenopathy. So he gets staged as 3A T3N1. So keep this case in mind. So this is a much more advanced situation that we're talking about with this patient. He had an EVUS. The EVUS was negative at 4R, 4L, and 7, but he did have positive 11R lymph nodes. There was no molecular testing done, but he has a PD-L1 of 90%. He was sent to a surgeon who then referred him to medical oncology, appropriately so. And the medical oncologist had the insight to send him for molecular testing, which revealed his EGFR mutation. So getting at that high PD-L1 in the setting of an EGFR mutation, we're just going to take a minute and come back to this concept to talk about why we wouldn't want to treat this patient with immunotherapy in this setting. The idea is that a lot of patients with EGFR mutations do not have the same sort of responses to immunotherapy. That's not to say that none of them can have a response, but the vast majority don't. And so the likelihood that this patient is going to have the great response to immunotherapy that we want is pretty low, even in the setting of a high PD-L1. You should just ignore that when patients have an EGFR mutation. And the problem is that we do actually have very effective therapies for patients with EGFR mutations. And there can be problems with toxicity if you give EGFR TKIs after patients have received immunotherapy. You deal with these complications much more than I do, but the point of this slide is just to show that there can be some pretty severe treatment-related adverse events that require hospitalization. Patients have to be put on steroids. These things, if you're thinking about this potentially in the neoadjuvant setting, these things could be problems for us. If you started immunotherapy while you're waiting for your biomarker testing to come back, oh no, now we have an EGFR mutation, and change to a different therapy, you can have a lot of toxicity related to
So
that.
it's not trivial, right? It's not like we can just switch people willy-nilly. There are real consequences.
That's why it's really important to get your biomarker testing done in someone who you're thinking about a neoadjuvant or a perioperative treatment strategy in them for these stage 3, stage 2 patients who you might think about treating with immunotherapy. It's really important that you do biomarker testing and look for EGFR mutations. There are a lot of studies coming out in the neoadjuvant space with targeted therapies. This is a really exciting and evolving area. So here, different targets, the drugs, and then there are a lot of studies that are currently open. We don't currently have any data from the major trials, but we will have data soon from NeoAdura, and I think we have a slide on that, maybe even next. So NeoAdura is going to be the first major large study to report out in this space. And what it's giving is neoadjuvant OC plus chemo for EGFR mutated non-small cell lung cancer. It's given for 3 cycles in the neoadjuvant setting. Patients are then undergoing a surgical resection. And then the adjuvant therapy is at the choice of the investigators. And this is about to be reported in just a few weeks at ASCO. So this could rapidly change things in the way that we think about these patients if the data is really strong in support of giving neoadjuvant EGFR TKIs to these patients.
And this is exciting because there's 3 arms in NeoAdora. There's a neoadjuvant OC, there's neoadjuvant OC plus chemo, and the control arm. So I'm very excited for this ASCO data.
Yeah. It's also really helped to get at the question as to whether or not the addition of chemotherapy is helpful in these patients. The nice advantage of these neoadjuvant studies is you get the early readouts based on path response. So if we see that there are big differences early on when you add chemotherapy to osimertinib, that might help influence a lot of practice patterns about that.
Yeah.
Okay, so now we're coming back to our case. This was the patient we had who had a large right upper lobe tumor, and he had his EBUS was negative for N2 nodes, but he does have a positive 11R. So for this guy, let's talk about what his options are and treatment considerations. So he was enrolled on NeoAdura, and he was randomized to the neoadjuvant OC arm. After 9 weeks, he had a big radiographic response. The mass shrunk to 4.5 centimeters, and the satellite lesion also significantly decreased in size, suggesting that that's probably the same tumor. But he had no significant change in the hilar lymphadenopathy, which we had noted on his initial scans. He underwent a surgical resection, a robotic VAT surgery with a right upper lobe lobectomy and a mediastinal lymph node dissection. There was severe fibrosis from the induction therapy within the hilum, but the patient tolerated the procedure well. Post-op course complicated by standard stuff, AFib. He was started on metoprolol and later apixaban. On pathology, he had a 3.5 centimeter tumor. The margins were all negative. He had 1 hilar node that was involved out of 18 total lymph nodes that were sampled. And then he was later placed on additional adjuvant OC.
And this is actually my patient, and he's still finishing his 3 years of adjuvant OC now, but is doing, very well.
Excellent.
And Gavit, while we're
doing this chat,
someone asked a very similar case. He said, what would you recommend for a 70-year-old patient fit with normal PFTs, 4 centimeter left lower lobe mass, probable N1 disease that is not accessible to biopsy, the lesion's EGFR positive? surgery plus OC, chemo plus surgery, plus minus OC. He's asking.
This is a perfect case to be answered by Neo-Adura. I think before we see that data, probably this is a patient who is going straight to surgery. If it's just N1 disease, it's not N2, 4-centimeter tumor, sound surgically resectable. The patient is otherwise fit.
Yeah.
However, depending on what comes out at ASCO, I think that this could definitely be someone that you might consider a neoadjuvant OC approach, but we need to see that data first.
But I mean, the good news is that even if you just take them straight to surgery, we have great options for the patient afterwards. I'll talk a little bit about some kind of beyond EGFR, and then we'll come back and answer some of these polling questions. I think this is where we've kind of figured out that neoadjuvant is a great new space. There's an adjuvant now for adjuvant osimertinib and adjuvant alectinib. But what about some of the other targetable mutations, right? We have all of these other targetable mutations. We have ROS1, we have NTRK, we have BRAF, we have MET. And we have all of these things, but each kind of patient population tends to be quite small, so we don't necessarily have a lot of data for them yet. And they're all a little bit different. You know, like EGFR has a really, really high response rate, but not all of the targeted therapies has the same response rate. KRAS G12C, we have targeted agents for it, but the response rate is not the same.
This is one of our chat questions, actually. It's related to, in biomarker testing, do you focus only on EGFR and ALK? Or is it a full panel? And then how does liquid biopsy come into play? And I would say this is a nice example where it's potentially good to have more information. But I think that the important point is, if you're really thinking about a neoadjuvant strategy, it's critical to test for EGFR and ALK. The rest is bonus. We don't really have, this is, great if you can find a match, but not as essential. But EGFR and ALK before immunotherapy are really important to test for.
And I would say, I'm going to show you this case of mine, but I would say if you are going to do NGS testing anyway, just do a full NGS panel. I mean, it may or may not change your treatment.
And liquid biopsy versus tissue-based. I think in early stage disease, we know that liquid biopsies aren't able to detect mutations in some patients. Hopefully that technology will get there, but right now it is possible to miss a diagnosis with that. But if you're in a situation where maybe there was insufficient tissue, sending that patient at least for a liquid biopsy to try to rule out EGFR, I think would be important.
Although you're right, like most of these earlier stage patients aren't going to have anything positive. So definitely tissue. So this is a very interesting case that one of mine, he actually went for many second opinions. I think he went to Yale as well. But so he had this, he's a very healthy guy. He's been followed with these CT scans for several years. And he was kind of diagnosed with this like ILD, NOS. This was a CT. He has disease kind of throughout that right lung. He finally came to get another pulmonary second opinion, and they ordered him a PET scan. And, it was like kind of this low-ish uptake, but there was uptake, and it was throughout the right upper lobe and the right lower lobe, and nothing clearly in the mediastinum. So you can see that it's kind of like throughout that right lung. And by this time, he was complaining that he had some symptoms of like occasional cough. And he felt like maybe occasionally at night he had some wheeze. So he undergoes, the pulmonologist here was like, you know what, we need to work this up further. And he undergoes an endobronchial biopsy, and it showed at first just we got an adenocarcinoma, at least in situ. It was insufficient for molecular genotyping. The lavage was positive for adeno, and they sent him to see me. And, this guy was otherwise this never smoker, very healthy guy. So I recommended another biopsy because I thought a very high pretest probability that he has something, right? Maybe he has EGFR and we can give him therapy. And I think I even counseled him, like, you will if I had to guess, I would guess EGFR. Of course.
We have some questions in the chat that are coming about smoking and how that impacts therapy. And I would say, I don't think that your smoking status impacts therapy, but it does increase the chances
Yeah.
that you might have one of these mutations. So the reason why we keep mentioning this and talking about it so much is because we know that these are more likely to occur in never smokers. So if you see a never smoker, that might be the person that you're sending back for a repeat tissue biopsy attempt.
Yeah. So, I mean, that's why I sent him back. He was very grumpy about going back for another biopsy. But I said, we need to do this. So we did. He undergoes another biopsy, this time 11R, and it was positive. It was positive for med exon 14 skipping. So two things. One, he wasn't expecting his nodes to be positive. And two, I had, kind of discussed maybe it would be EGFR and it comes back as med exon 14 skipping. So I'm going to pause there for a second. Now what do we do? He's got disease throughout that entire right lung. It's med exon 14 and he has a lymph node. So what do we do?
Surgeons are going to do a right side pneumonectomy for this patient. It's a very tough call.
I don't know. So we thought about it for a while. We debated pneumonectomy. By the way, he just bought like a really nice house in I don't know, wherever people go skiing in Park City. And he just bought this house and he was really, really nervous that he wouldn't be able to ski if he had a pneumonectomy. That was like his first question to me. Like, just bought this house. I go skiing all the time. What is that going to mean? So I gave him capmatinib, which is a med exon 14 inhibitor. And like a few days after starting, he immediately felt better. And you can see that the disease had regressed pretty quickly. And so during this time, he sought many surgical and medical opinions. He went to Yale. I think he went to MSK. He went to a couple places in Jersey. He went to Greenwich. He went to all sorts of places. And he looked for a lot of different opinions. And Gavin, I'm curious now that, okay, so he's doing a little bit better, but it's still throughout his right lung. He still has N1 disease.
Yeah.
What do you want to do for this man?
It's a tough call. We did see him at Yale, and we had some other things that I'm not going to bring into this discussion, but, it's definitely a complicated case. And it's hard with the TKI therapy because we do think that these work a little bit differently than immunotherapy. So, our suspicion is that there's probably still some disease in there. And how can you provide him the best chances of survival if you currently have a handle on things, but maybe this is not going to have a sustained response?
Right. And I think that's really what we discussed with him because we know that these TKIs, at some point, these patients all have acquired resistance. So when he asked me, like, are you going to cure me with the capmatinib? I said no. He really wanted to be as aggressive as possible. And I explained to him that capmatinib would not be curative. Some surgeons were a little bit against the idea of doing a pneumonectomy, given that he had N1 disease. On the other hand, he did not have N2 disease, and we had been, he had these prior chest CTs, and he's had this disease for a while, so we kind of knew the natural history of his disease, and it certainly hadn't gone to the contralateral lung yet. There's no obvious N2 disease. So we decided he was on neoadjuvant capmatinib for several months, and then he underwent the pneumonectomy. And after that, then there was like additional questions. Do we give him adjuvant chemo? Again, he wanted to be as aggressive as possible. So we gave him adjuvant chemo. For us, it's like cisplatin is a tougher drug, but he wanted the best he could do. So we gave him that. Again, not the easiest thing in someone who undergoes a pneumonectomy. He got 4 cycles of adjuvant chemo, and then we put him back on adjuvant capmatinib, right? And like, there's
no randomized data in this space. You're just making it up as you go, but trying.
So he sent me this video this past winter. It's just, here's a picture of it, but I don't know if you can see it. But he basically, oh yeah, see, that's him, and he's skiing in Park City. He's wearing a little oxygen thing, but he wanted me to see that, and I thought it was really a really nice kind of interesting case, right? That I'm hoping that we'll have more data for all of these different targets. So LCMC4, the LEADER trial, is a trial that a lot of us have at our institutions. It's looking at all of these different actionable drivers and looking to see whether or not we can have these different match trials. So at Columbia, we have Nautica 1. At some of the other sites, they have different ones, but this was a really nice collaboration with industry and academia. The industry partners had their own kind of trials matched into it. And I think you can see here that we're continuing to screen for patients. So all surgically resectable patients can go on this. Then we do molecular testing on them. And what you can see here is Jamie Chaff had presented this. This is really nice because what it shows us is that patients really need to have tumor NGS testing, biomarker testing in the tissue, because when you do it, like an actionable oncogene was found in almost half the patients, as opposed to the liquid biopsy where it was found in many fewer patients. And so whether or not in the future neoadjuvant, BRAF therapy, neoadjuvant exon 14 therapy, all of these kind of remain to be seen, but this is kind of ongoing and I think really important. We're also looking at pathologic response, complete and major path response, viable cells, persister cells, and these will kind of read out over time.
So a space that's just exploding and kind of, demonstrates the need for testing these patients. Because if you don't test, you don't know that these options are available. And so that's the real critical teaching point, I would say, is that, yes, these patients need testing as early as possible. We have some questions about a stage 1A with high-risk features. Would you consider it in that patient? This was, there have been a lot of topics on that in some of the lung sessions earlier today. And so how do you we don't cure all stage 1A patients. We'll need to see more data in this space, but it's thought-provoking, and certainly there are stage 1A patients who I'm sure benefit. The challenge is how do you identify those patients from the rest of the group, the majority of who are cured or disease-free with just their surgical resection alone.
All right. Oh, someone asked a pathological response.
In case 2, I think it was after case 2 that one.
Oh, that was after case 2?
Makes sense.
Yeah. So
there was residual disease.
There was residual disease, and there was not a path CR. I don't think he even met a major path response. And actually, that is what we're seeing with some of the EGFR-targeted therapies, that we're not seeing that same level of path CR that we're seeing with immunotherapy.
We probably, we'll have more data with Neoadura, but one of the largest series that's out there came from Colin Blakely at UCSF, and he gave patients 2 cycles of neoadjuvant OC without chemotherapy. His pathologic response data weren't on the same level as what we see with neoadjuvant immunotherapy. And so it may be that when we're thinking about neoadjuvant TKIs, we just are expecting different things, and it doesn't mean that they may not be providing a benefit, but we have to kind of see what the data shows. We still don't have data in this space, but maybe these are drugs that are used more for downstaging, for facilitating an easier surgical resection. If you can shrink a larger tumor to a smaller size, does then that become a minimally invasive operation? And again, if we're not giving targeted therapy in the neoadjuvant setting for a stage 3 patient, what are they getting? Because it shouldn't be immunotherapy. So it would be nice to have a treatment strategy where, for stage 3s, I know we like to give some sort of systemic therapy before a surgical resection. And so just to have a way to deliver something for a few cycles and take that patient to surgery so they don't suddenly met out with,
And I'll put out there that for stage 3 unresectable patients, there was a similar trial called Laura that looked at chemo RT followed by osimertinib, and that trial similarly had a really nice hazard ratio. So I think if the patient has stage 3 and can't get surgery, we have a great other option for them. That's what I tell them.
If they end up on a neoadjuvant treatment strategy that then doesn't lead to a surgical resection, there's still a great option.
Yeah, absolutely. What else? Let's see. And you guys are welcome, if you have questions, to come up to the microphone, please.
And here's one about osimertinib acquired resistance affect your therapy options and what's your experience regarding resistance. I assume this might be in the adjuvant setting where patients are on it for a longer amount of time. Do you have concerns, or have you had issues with that?
I have to be honest, I haven't had any patients recur who have been on adjuvant OC yet. That being said, that was everyone's concern initially, but with the OS data being positive, I think that that's still the way to go. Um, Definitely patients who have been on OC for a while have a different pattern of resistance than in the past when people were like on erlotinib followed by osimertinib. So there are different patterns of resistance. And I would say the most important thing that we do is we biopsy at acquired resistance, because occasionally patients can actually have small cell transformation. And we see this, and that's like the one time that it's such a different disease entity entirely that it like drives you to do a whole different type of treatment. And so for that, you can't do liquid biopsy. You really need to do a real biopsy.
Another question here about targeted therapies. They're only approved currently in the adjuvant setting. But if we start to see more trials come out in the neoadjuvant setting that are positive and show a benefit, how are we going to adjust how we think about these patients? My guess would be that we would adopt a perioperative approach. And so if we're seeing a benefit to neoadjuvant therapy, give a few cycles there. And then the data from ADAURA is just so strong. It's hard to think that neoadjuvant treatment alone would be sufficient in these patients, and I would probably still want patients
Agreed.
to be on a full adjuvant course.
We also had the ALK arm for Nautica 1, so patients with ALK rearrangements got pre-op alectinib followed by post-op alectinib, and again, like my patients all like cleared and looked really good. So I do think that adjuvant though is still really important. And I would say the other thing, Gavin, when we look at like NeoADAURA results, right? I'm not expecting that same magnitude that we saw with like ADAURA, because if you think about it, these patients are getting neoadjuvant for 9 weeks, whether it's chemo or chemo plus OC or just OC, and then they're still getting 3 years of adjuvant OC, right? So it's makes it harder to tease out exactly where that survival benefit is coming from.
Right.
Okay. What else?
Is multi-station N2 a contraindication for upfront surgery and adjuvant OC? I mean, I would say it's not multi-station N2, not a contraindication, but again, I think that if we just go back to kind of our roots in surgical training, multi-station N2 is a marker that this patient could have more advanced disease, and I think that that's where I would take that one. So I like the idea of giving a few cycles of therapy, making sure this is not some super aggressive treatment-resistant bad biology tumor that suddenly has a lot of other mets that pop up in the next month or two. But I don't think it would be wrong if you can think you can fully dissect all the disease that's present to take that person at the moment with an upfront surgical approach followed by adjuvant OC until we start seeing the NeoADAURA data. And if that is positive or it gives us an indication that might be helpful, this is the perfect patient for going on some treatment strategy like that. Is someone who it's a little questionable to go straight to surgery. I wouldn't say it's wrong, but we just know multi-station N2 is a marker for worse disease and a higher likelihood of having undiagnosed micrometastatic disease elsewhere.
And I would also point out that now that we have LAURA data, there's less pressure on the surgeon to have to clear all of that, bulky nodal disease, right? The patient can get chemo radiation followed by OC and have a very nice response. So I think the fact that there are other treatment strategies as well can maybe shape some of your decision making.
And here's a tricky one. Do you want to read that last one? You want me?
How to choose neoadjuvant therapy for patients with N2 disease harboring an EGFR L858R plus TP53 mutation in your clinics. Do we give him neoadjuvant OC with or without chemo, IO with chemo, chemo alone, or upfront surgery?
Well, so I think we've talked about how it's really important if you do have these EGFR mutations, these are not the patients you want to put on neoadjuvant immunotherapy. And I would say like that to me is a clear, like definitely not that answer if you're doing a process of elimination, multiple choice test question. But the rest, I think, a lot of things are reasonable here still.
Yeah. I think the bottom line, I think that we're just saying is do the testing so you know what treatments to give or not to give, and also send to tumor board and have a big multidisciplinary discussion, right? We want surgeons and med oncs and pulmonary and pathologists to all be involved.
As much as we still have, more options in the space, certainly like all these new questions that we haven't had to think about in the past are now coming up. And so it is a really complicated space. And so making sure you do have that multidisciplinary discussion, I think, is really critical. And the sooner you can have these conversations, whether you're a medical oncologist or a surgeon, the sooner you can touch base with your team about this, the better, before starting someone on a pathway that may not be the right one.
Yeah, totally agree.
Thank you for joining us.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent educational grant from AstraZeneca. To access all materials for this activity, visit peerview.com/UKV860.